All right, good afternoon, everyone, and welcome once again to this review session on NCLEX. And this time we're going to talk about a frequent item in the NCLEX, and that is pertaining to diabetes mellitus. And we're now going to talk about complications of diabetes, namely DKA and HHS. So before I get started over here, I wanted to ask you a question. So let me just launch this. Okay, so it has been a misconception that diabetic ketoacidosis only occurs in type 1 diabetes. During the presentation, you will understand that it actually is a complication to diabetes that occurs in both type 1 and type 2. Uh, in the old days, we thought that it only happened to diabetes type 1. However, evidence have shown that actually it does happen in both diabetes type 1 and diabetes type 2. Okay, so with that in mind, let's go ahead and talk about diabetic ketoacidosis, which is an acute major life-threatening complication of diabetes. And they're actually a conglomeration of three particular findings. And they are that we have hyperglycemia, and we also have acidosis and the presence of ketones in both the urine and also the blood. So that's called ketonuria and ketonemia. Now, tracing back on the pathophysiology of diabetic ketoacidosis, let's begin to understand that this is a consequence or a result of an absolute or perhaps a relative lack of insulin. So whenever you have lack of insulin, there's going to be counter-regulatory mechanisms that are going to be more predominant. So when I talk about um, let me just, okay. Counter-regulatory mechanisms. We all know that in the body, there's always going to be a balance between insulin and glucose. And the glucose that we're talking about are going to be a result of, let's say, secretions from your endocrine gland in the form of glucagon. Or it could also be as a result of breaking down of stored glucose. So where is stored glucose finally seen? It is seen as glycogen, and it usually is in the liver. And then, of course, we also have our stress response. So our adrenal gland could also create or cause glucose to rise, as well as growth hormone. Now, despite all these things that produces glucose, the body is able to keep up with that because usually what happens is that there's a balance between insulin production and the glucose production. But what happens in diabetes is that when there is a lack of these, therefore, we're going to have a predominant effects of glucose known as hyperglycemia. All right. So when there is not enough glucose, actually the body can compensate for that. So let's say that there is a decrease in glucose, and the body can now compensate for that by breaking down glycogen that's stored in the liver. Or in cases wherein there's going to be a decrease in insulin, what's going to happen is that there's going to be a shutting off of the glucose production as a normal mechanism. But in diabetes mellitus, what happens is that this goes awry, and the insulin production is either decreased or is not utilized. So let's take a look at the general pathophysiologic mechanisms that occurs in, let me just, diabetes. Oh, what happened over here? I'm not gonna do this again. It's hard to erase it. Let's see. Sorry about that. All right, so what I have just told you is that diabetes mellitus is when there is an absolute or relative lack of insulin and an increase in the counter-regulatory hormones like glucagon, the cortisol growth hormone, and epinephrine is going to increase our sugar levels without a consequential or a balancing increase of insulin levels. So whenever this happens, what's going to happen is this. The cells are now going to, oh geez. Okay. The cells are now going to be hungry. So if these were the cells, usually they are going to have glucose as a primary source of energy. And glucose is going to be delivered by passive transport through the hormone insulin. So in other words, glucose usually cannot enter the cells without the presence of insulin. So what happens when you lack insulin is that the glucose stays in the bloodstream. So you will have an increase in glucose in the bloodstream, known as hyperglycemia. And meantime, the cells are hungry. So if they're hungry, they're going to look for other sources of energy. And where is that source of energy that they will look for? Well, they're going to look for the breakdown of fat, which increases serum fatty acids. So whenever you have free fatty acids as an alternative energy source, so instead of glucose being your energy source, you now have free fatty acids. And what's the consequence of producing free fatty acids? Well, this is going to result in the accumulation of metabolites, and those metabolites are going to be predominantly ketones. So this is exactly what happens in diabetic ketoacidosis. Because the cells are not getting enough glucose, they look for other sources of energy. And the liver now is going to produce other sources of energy. And this is going to utilize fat, and the utilization of fat as an alternative energy source results in accumulation of acids and their metabolites, namely, or most importantly, ketones and keto acids. So that basically is the result of not having enough insulin. Now, as you see, what usually happens when we have a lot of acids, ketones and acids, we're going to have metabolic acidosis. And this metabolic acidosis is going to now cause a respiratory compensation. And this is what is known as Kussmaul's respiration. All right, so pausing from what we had talked about, the pathophysiology of diabetes, what happens to serum potassium and why? Does anybody know? What happens to serum potassium when you have acidosis?
It increases?
Okay. Yes, okay. It increases in the extracellular space. Very good. So let me just erase that thing over here. Oh my God, it bothers me. It's there. All right. Good. I'm not going to use this feature anymore. All right. Okay, so what is the predominant intracellular electrolyte? If this is the cell, what is the predominant electrolyte over here? And this is the extracellular fluid, like the vascular space.
Inside the cell is the potassium, extracellular is the sodium.
Very good. So potassium is going to be predominant in the intracellular compartment, and sodium is the predominant extracellular electrolyte. Okay. So, however, when you have a lot of acids is going to be those that contain a lot of hydrogen. What happens is that hydrogen ions are now going to come over here and kicks out this potassium. Potassium now goes into the extracellular fluid compartment. So you're going to have an exchange of where potassium is going to be. All right, understand that first. So initially, you're going to have an increase of serum potassium or potassium in the serum. So you will have hyperkalemia. Okay, so acidosis always drives potassium to leave the cell to go into the extracellular compartment. Now, in the meantime, when you have a lot of glucose, and I'm going to change my, okay. So if you have a lot of glucose over here in the bloodstream, the concentration of the blood is going to be hyperosmotic. In other words, because it is so concentrated, it is now going to pull water into the vascular bed. So water is now going to rush over here. So when you have an expansion of the extracellular fluid compartment, you're going to have diuresis because of the high volume of fluid in the vascular space. When you have diuresis, what happens to potassium? When you have diuresis, what happens to potassium?
It's wasted.
Accumulates or no?
You eliminate the potassium through the urine.
Oh, okay.
So because of so first you're going to have hyperkalemia, then it is going to be followed by osmotic diuresis. And as a result of the osmotic diuresis, you will now have a lower serum potassium or hypokalemia. Okay, so what happens to potassium is the question. And the answer is initially there will be hyperkalemia. But once the patient develops osmotic diuresis, and that is because of the pull of glucose of fluid from the intracellular compartment, then this is going to cause a decrease in potassium. Okay. So,
Professor, I'm sorry, one question.
sure.
Yes, for example, if in a question they ask about the diabetes ketoacidosis So you said it depends. So what is the timing to answer if it's hyperkalemia or hypokalemia? So
Okay.
which are the keywords that we should look for so we answer, the right the right answer?
Very good, very good. Okay, before diuresis, okay, if the question is just merely acidosis, what happens to your electrolyte levels in acidosis? Then what happens is that there's going to be hyperkalemia, okay? But the key word is once the patient develops diuresis, what's going to happen to their potassium levels? It's going to go down. So it will be hypokalemia. Okay? That's very, very good question, Patricia. Excellent. All right. Now, look at my drawing now. And I said these blue things represent water. This water is going to go into the vascular space. Where is this water coming from? Where is this water coming from?
It's coming from the cell.
From the cells. It's coming from the cells. So if you remove water from the cells, what's going to happen? You will have dehydration. Where is the dehydration from? Intracellular compartment or extracellular compartment?
Intracellular.
Intracellular compartment. So in addition to losing potassium, you're losing fluid from the cellular space, the intracellular space. And that is why in diabetes, there's intracellular dehydration. Okay? So that's the answer to the question of what happens to potassium and why. So let's go now to tracing the pathophysiology of ketoacidosis. So first of all, we have to have hyperglycemia. And when hyperglycemia occurs, there is an increase in plasma osmolality. Do you remember what I said about the concentration of glucose in the blood vessels? The high concentration of glucose in the blood vessels is what is called an increase in plasma osmolality, meaning to say it pulls fluid into the vascular space. So when that happens, you will now develop dehydration. And as a result of too much water going into the vascular space, you will develop diuresis. Okay, so do you understand? You're having diuresis, and at the same time, you're dehydrating the cells. All right? Now, when you dehydrate the cells, or when you have osmotic diuresis, then you're going to have a decrease in your extracellular fluid volume. And in addition to that, electrolyte losses. This would result in shock, in a decrease in glomerular filtration rate, and therefore it would cause more acidosis. It will increase BUN, and it still will increase your glucose. So this is the pathophysiology of your diabetic ketoacidosis. All right, so what are the causes of diabetic ketoacidosis? As we said that diabetes can occur in patients with diabetes mellitus, most frequently in type 1, but it could also occur in around 10 to 30% of cases occurring in type 2 diabetes mellitus. Now, the most common scenario why individuals with diabetes usually develop diabetic ketoacidosis is because they usually develop an infection. And when they have an infection, the demand for insulin is greater. And if they don't increase their insulin dose, it is now going to cause ketoacidosis. So, important. This is going to be the most common cause of diabetic ketoacidosis. So what happens when you're sick? When you're sick, when an individual with diabetes is sick, they need to increase their insulin dose. Unfortunately, patients sometimes do not recognize that there is a need for an increase in their insulin dose when they are sick. All right? Now, the other thing is that many people who are diabetic usually miss their insulin, which is also another common cause. And in this particular problem, it is very common among adolescents. And this usually has come out in the NCLEX, which population is going to likely forget to give their own medications. And that is the adolescents, because of peer pressure and sometimes because they're so engaged with activities, they forget to adhere to their insulin therapy. Now, other physiologic stresses like myocardial infarction, maybe sepsis or trauma could also cause diabetic ketoacidosis. Stress by a secretion of catecholamines, which include your glucagon and other cortisol, will lead to ketoacid production and therefore precipitate diabetic ketoacidosis. Certain medications, such as glucocorticoids, and when I say glucocorticoids, I'm referring to steroids. And other some antipsychotic agents usually can also precipitate the increase of your glucose and carbohydrate metabolism, and therefore this has to be also considered. And then, of course, sometimes what happens is that these individuals do not even know that they have diabetes. And so they're going to be newly diagnosed when they already have a diabetic ketoacidosis. So in some cases, this is the initial clinical presentation who have not been previously diagnosed with diabetes. Okay. So those drugs that are very commonly associated with your diabetic ketoacidosis is going to be this antipsychotic agents, namely clozapine or clozaril, or olanzapine or Zyprexa, and risperidone. And we also know that cocaine and alcohol could do that. All right? So infection, the most common would be pneumonia, sepsis, and urinary tract infection. Other things, such as the lack of insulin, could include also non-adherence to insulin, as well as in patients who have an insulin pump, there might be a failure of the mechanical components of the pump. And then, of course, sometimes there's going to be other physiological stressors like a CVA, a myocardial infarction, and so on. So those are some of the causes of diabetic ketoacidosis. So when these individuals develop diabetic ketoacidosis, what are the symptoms? Well, they present with myriad of symptoms, usually within several hours after an inciting event. So what are the most common symptoms? Well, polyuria and polydipsia. Polydipsia is increased thirst. Polyuria is increased urination. And sometimes more severe presentations, which might include, for example, weight loss, vomiting, weakness, and mentation changes. So as you could see, the other symptoms focuses on symptoms of dehydration. So what does that include? Well, fever, for one. Fever is not necessarily from infection, but it could be as a result of your dehydration. Dry skin, dry mucous membranes, decreased perspiration, and of course, labored respiration, which is Kussmaul's respirations. And sometimes you would smell the sweet odor of their breath. Now, I am sure, or I don't know, I'm assuming that you probably haven't encountered this in your clinical, but once you become a nurse and you encounter this, you will never forget that smell. It's a very, very sweet smell, but it also smells like acetone. So I know you ladies paint your nails, and sometimes you use acetone to remove the old nail polish. So the breath is sweet and acetone-like in its character, and you will never forget that. And that's called a ketotic breath. Ketotic breath. Now, because of the stress, there will be tachycardia as well as tachypnea, and also because of the dehydration, the patient will also complain of abdominal pain. Okay, so those are the signs and symptoms of diabetic ketoacidosis. So let's go to another poll, and this time, which of the following is going to be recognized causes of DKA as the most common? All right. So remember, the most common is that they do not know that when they get sick, they need to increase their insulin dose. And that is usually why they get in trouble. So the correct answer here is letter C, the underlying concomitant infection. Okay, so what are the findings on physical examination? Well, most of the patients with ketoacidosis will present with features of hypovolemia. And the hypovolemia is from gastrointestinal or renal fluid and electrolyte losses, as we had already talked about. So in severe cases, patients may be hypotensive and may be displaying or having signs and symptoms of severe shock. They may have a rapid and deep breathing, and this is going to be called Kussmaul's breathing. So Kussmaul's breathing is an effort to get rid of excess acid. So they usually blow for a long period of time. So the exhalation phase of their respiration is prolonged. So it's something like this. Because they're trying to eliminate a lot of acid to their respiratory system. And again, of course, their breathing could be associated with a fruity odor or an acetone smell. And this is because of the acetone production as a result of ketoacidosis. So a history of rapid weight loss is a symptom in patients who are newly diagnosed type 1 diabetes. My brother is a very, very good example of this. My brother didn't know that he was diabetic. All of a sudden, he got unconscious and was rushed to the emergency room and was found out to have a blood sugar that was around 400. And this was the first time he found out that he had diabetes. He never knew that he had diabetes. So, but before that, he was losing weight. And therefore, this is a classic example of how a history of rapid weight loss is a symptom in patients with newly diagnosed type 1 diabetes. All right, let's go now to the strict criteria for the diagnosis of diabetic ketoacidosis. Now, hyperglycemia obviously is going to be the typical finding. You cannot have diabetic ketoacidosis if you don't have high blood glucose levels. So hyperglycemia is the typical finding, but it is usually defined as a blood glucose above 200 milligrams per deciliter. Okay, so the hyperglycemia usually is above 200 milligrams per deciliter. And of course, it is accompanied by metabolic acidosis with ketonemia as well as ketonuria. So these are the three things that must be present in order to diagnose a patient with diabetic ketoacidosis. Now, we said the presence of ketones in the blood and in the urine. But biochemically, it is going to be a serum ketone concentration above 5 MEQs. So if you have a ketone concentration of only 2, that doesn't mean to say that you would have diabetic ketoacidosis. You must have a ketone concentration, serum ketone concentration above 5 MEQs per liter. Okay, so what else are the laboratory results that points to the diagnosis of diabetic ketoacidosis? Well, you would have an increase in anion gap, and I will explain this in detail in a little bit. You will have an increase in serum osmolarity. Now, you remember that osmolarity is the concentration in the extracellular fluid compartment, and therefore you will have an increase in your serum osmolarity. And other tests will be useful, like CBC. It might show us that the patient is having an infection. For example, the BUN in creatinine is going to be very helpful. The electrolytes, as well as ABG, blood culture, urinalysis, ECG, and chest X-ray. All these things are going to be very, very important. Now, again, what happens to your electrolytes? Initially, your serum potassium levels may be elevated, but after the patient is now going to have diuresis, the patient can develop hypokalemia. Okay, so let's go to this anion gap. How many of you understand what anion gap is? This usually is something that that nurses are oftentimes confused about. Now, an anion gap is the best way to determine the acidosis progression. Okay, so whenever we have acidosis, there are two causes of acidosis. So why do we develop acidosis? Well, acidosis can occur because there might be an increase in acids, or the other one is that there's a decrease in bicarbonate. Okay, so let me repeat. There are two types of acidosis. One is caused by an increase of acids, and the other one is caused by a decrease in bicarbonate. Now, diabetic ketoacidosis results from an increase in acids. So in order to detect what kind of acidosis you're having, you need to look at the laboratory value known as your anion gap. So let's explain what anion gap is. In the body, there's always going to be equal amounts of anions to cations. Do you remember what an anion is? An anion is going to be a negatively charged, and the cation is going to be a positively charged particle. So positive is equal to negative ions. this is going to be reflected by this one. This is the cations. I'm just going to magnify this. If you add the number of positively charged ions in the body, like sodium 142, and you add this 5 of potassium, 5 of calcium, and 3 in magnesium, that would be 155. You see that? So our cations are usually 155 in number. Notice also on the number of anions. Anions are your negatively charged ions, 105 plus 25, 130, plus 6, 7, 8, and 16, that's also 155, okay? So in the body, we usually have equal numbers of anions to cations. Do you understand that so far?
Yes.
Okay, great. So the number of cations, as you could see over here, and the number of anions are right over here, we have small amounts of the following: potassium, calcium, and magnesium. And over here, we have hypophosphate, we have sulfate, we have organic acids and proteins. These are the small numbers are called unmeasured cations and anions, unmeasured. Which one has more unmeasured ions? Is it the cations or the anions?
Anions.
The anions. Okay. So the number over to the left, this is 13 right over here, right? 5 plus 5 plus 3 is 13. How about over here? 6, 7, 9, and this one over here is, let me just erase that. 16, so 16, 22, 23, 25. So we have 25 of unmeasured anions. Do you get that so far? Do you understand where I got the 25 and the 13?
Yes.
Okay. So 25 minus 13 is what? 12, right? Okay. The difference between the anions and the cations that are not measured is usually 10 to 12. So do you understand the optimum value of a cation, an anion gap is 10 to 12. This is normal. Okay? Now, however, if you have a loss of bicarbonate, you will have acidosis, but a normal anion gap. If you have a acid retention, such as what happens in diabetic ketoacidosis, you will have a high anion gap. Okay? So a high anion gap means to say that you have acidosis. So let me just explain that further. So supposing you did a test, a blood test, and the patient finding is that the patient has acidosis. Okay. And now your cation anion gap is 10. What is the cause? Is it a decrease in bicarb or an increase in acids? Okay, is the anion gap normal? What was the normal anion gap?
From 10 to 12, you said?
10 to 12. Okay. So is the anion gap normal?
Yeah.
Normal. So the problem here is that the acidosis is caused by a decrease in bicarb. The patient might be vomiting and therefore losing a lot of acids to the GI system. However, if the anion gap is 30, what is causing the anion gap to be 30, to be high? Is it because of a decrease in bicarb or an increase in acids? And the answer to that is it's an increase of acids. So an example of that would be diabetic ketoacidosis. So in patients with diabetic ketoacidosis, they will have a high anion gap. And we use this then to see whether or not our interventions are working. So the patient might have initially an anion gap of 30. Now, once you treat the patient, hopefully it will now go to 10 to 12 because that's the normal anion gap. Okay, so we utilize the anion gap to monitor the effectiveness of treatment. And that is the reason why the physician will usually order an anion gap every 3 hours. Now, couldn't we just measure the acidosis by doing an arterial blood gas? And the answer to that is yes. But you don't want to be sicking the arteries of the patients every hour. And that is why they do not order an ABG every hour. Rather, we just rely on the anion gap. Did I make clear? Okay, so the question in NCLEX would be, how do you evaluate the effectiveness of treatment in patients with diabetic ketoacidosis? I don't know why I'm looking over here. It's because the screen. All right, the answer to that is to monitor the degree of acidosis in a patient with diabetic ketoacidosis, we monitor the anion gap. What is the goal for the anion gap?
To see
What is the... Yes, we want the anion gap to return to 10 to 12 milliosmoles per liter. Okay? All right, so I hope that you understand now what the purpose of an anion gap is. So this is going to be the diagnosis and the increase in an ion gap. And of course, you're going to have as a goal for treatment to decrease the anion gap to 10 to 12. Okay? All right. So let's now have another poll. Very good. You are all paying attention. That means to say that the correct answer here is going to be letter C. Notice that it has a ketone level above 5 MEQs. And this is going to be the standard. Of course, the blood glucose has got to be over 200 and the pH has got to be less than 7.35. Great. So let's now go to the management of DKA. So whenever we have DKA, I want you to remember the acronym DKA, because that's exactly how we're going to treat the problem. D first, the dehydration. Then we are going to address the potassium or the electrolyte abnormality next, and then the acidosis also as the last one. Okay, so we are going to start by treating the dehydration first. So what do we do after initial stabilization of circulation? Well, we're going to do or address the dehydration. The correction of fluid loss makes the clinical picture clearer, and it's a lot easier to correct acidosis once you treat the dehydration. So we usually give normal saline or Ringer's lactate in this particular case. And of course, we might have to use special types of solutions in order to treat the problem, okay? So the hallmark here is once the serum glucose reaches to around 12 to 14 milliosmoles per liter, that is around 216 milligrams. We are now going to use D5 in water or D10 in water to IV fluids to maintain the serum glucose. And you're saying, Dr. Tom, are you crazy? The patient had hyperglycemia. Why then are you giving dextrose, either 5% or dextrose 10% in water? All right. So we don't want a rapid correction for very obvious reasons, and I will talk about that in a little bit. Okay, so notice that what we're going to do is we're going to give normal saline or Ringer's lactate, and after that, we add D5W or D10NW. So there are three types of solutions. One is what's called isotonic. The other one is hypotonic. And the other one is hypertonic. Okay. So whenever we have two compartments of fluids right over here, the extracellular fluid and the intracellular fluid, when we give a solution which is isotonic, like normal saline, for example, or Ringer's lactate, what happens is that if you are infusing it over here, there's going to be equal distribution of that fluid. So it goes from intracellular, extracellular to intercellular, and so on and so forth. So the movement of the water is going to be between intracellular and extracellular fluid compartment. So if you don't want that fluid to stay in the intracellular or extracellular fluid compartment, you would want to give an isotonic solution. So for example, if you have a patient that needs an IV to be kept open, what fluid do you usually use to keep the IV open?
Saline?
Normal saline or D5W, and or normal or Ringer's lactate. Okay. So these are examples of isotonic solution. Now, a hypotonic solution means to say, okay, so if this is the extracellular fluid compartment, so this would be your veins, for example, and this is your intracellular fluid compartment. A hypotonic solution, if you give a solution that is weaker than the concentration of the intracellular fluid compartment, then this is what's called hypotonic. Do you understand that? So a hypotonic solution might be a half normal saline or maybe a fourth normal saline. And these, of course, is going to be very important. What is the purpose of a hypotonic solution? in this example, where would fluid go? So if you're giving an IV here and only giving one particle compared to the many particles in the cell, where would water go?
Extra
On the
E.
Your idea.
extracellular to the intracellular.
Intracellular. So the water is going to go over here. So you are feeding the cell. Understood? So that's the reason why usually when we have patients who are dehydrated and there's cellular dehydration, what we're going to give them is we're going to give them a hypotonic solution. So do you understand? It does not stay in the veins. It stays in or goes into the cells. So anytime you want to feed the cell, you want to give a hypotonic solution. Understand that?
Yes.
Okay. All right. Now, let's say that you're going to, again, this is your extracellular fluid compartment, and this is your intracellular fluid compartment. And we're now going to give an IV, and the IV has more particles than the particles in the intracellular fluid compartment. Where would water go?
Outside the cell. E. Extracellular fluid.
Okay, good. From the intracellular to the extracellular. So you're going to pull water from the cells. So when do we give this? We usually give this when there's inflammation or swelling in the cells. So you have heard of, let's say, D10W is a hypertonic solution. Mannitol is a hypertonic solution. TPN is also a hypertonic solution. Okay? So what happens is that you decrease the swelling in the cells. Now, in patients with diabetic ketoacidosis, notice that we have cellular dehydration, and that is why we're going to give this solution after we had given isotonic solutions. And in addition to that, we also want to give dextrose. Now, the reason why we want to give dextrose is because of the fact that whenever you are rapidly putting fluid into the cells over here, what's going to happen is you could have an overhydration of the cells. And overhydration of the cells can burst these cells. So dextrose is usually incorporated, okay, in order to counterbalance that particular problem. So as you could see over here, we give initially normal saline or Ringer's lactate. So do you understand? And now we're going to add D5 water or D10N water. And we usually are going to give a hypotonic solution. So you usually have a half normal saline. So dextrose in 1/2 normal saline is usually given in order to feed the cells. All right, so let's now go to the correction of potassium. Now, whenever the patient is going to, remember, initially is going to be hyperkalemia, and then eventually it's going to be hypokalemia, primarily when there's now going to be your diuresis. So what we're going to do as far as potassium is concerned is it's going to involve the administration of potassium first. So if there's going to be a decrease in potassium right over here, oh my God. If you have hypokalemia, so you remember it could either be hyperkalemia or hypokalemia. If it's hypokalemia, then we would need to give a bolus of potassium, and of course, to maintain the serum potassium level at around 4.5 milliosmoles per liter. If the serum potassium is going to be high, then what we're going to do is we're not going to give insulin until after the potassium reaches towards the normal. Why is that? Why are we not going to give insulin when the potassium levels are going to be less than 3.3? So if you have hypokalemia, do you want to treat it right away with your insulin? And the answer to that is no. Okay. So you remember that over here, you have a serum potassium that's going to be very high. If you give insulin, what's going to happen is insulin will now pick up glucose. Along with it, it will pick up potassium and enter the cell. So therefore, what's going to happen? Potassium is now over here and glucose is going to be utilized over there. You're now going to cause hypokalemia. Okay? So we don't want to give insulin for patients who have hypokalemia until we are going to, manage the hypokalemia first. So it is always going to be important that we are going to correct the electrolyte imbalances before we give insulin. So here is what happens in NCLEX. If patient has a potassium of 3.0 and blood glucose of 300, what should be corrected first? Your answer?
The potassium,
Correct.
because it's
Why
going
do
to
you-
change the arrhythmia. It's going to cause dysrhythmias.
Yeah. Well, the reason too is if you give insulin, you remember what I said, if you give insulin. Okay. So the potassium here now is only 3.0. If you give insulin, what's going to happen? Insulin is going to pull the glucose and potassium back into the cell. What happens over here now? It will now become less.
Go down.
2.0, and the patient will have a cardiac arrest as a result of an arrhythmia. Okay? So that is why it's important to understand that we treat the dehydration first and then the potassium next. So going back to fluids, we said that we're going to give isotonic sodium chloride or Ringer's lactate during the first 3 hours. And once the patient is euvolemic, meaning to say the blood pressure is now stable, we switch them to 1/2 normal saline. Do you understand why we switch them to 1/2 normal saline? I hope you do. I said that the reason why you switch them to normal saline is what does a hypovolemic,
Hypotonic.
hypotonic solution do? It feeds the cell.
Mhm.
Okay? All right, so you had a question. Did somebody have a question? No? Okay. And when blood sugar now decreases to around 200, we add dextrose with 1/2 normal saline. So do you understand this? So when you are taking care of a patient with diabetic ketoacidosis, you're always constantly drawing blood and also changing IV solutions. So do you understand why we changed the IV solutions?
Yes.
Great. Okay. So let's go now to this poll right here. All right. So do you want to give insulin if the patient's potassium is 2.5? What did we say would happen?
It will drop more the potassium.
Very good.
Yeah.
So the correct answer here is letter B. You need to hold the insulin and notify the doctor of the potassium of 2.5. Remember, when insulin is given, it helps to take potassium back into the cell, which will cause potassium blood levels to fall. Insulin therapy is to be started only if the patient's potassium level is 3.3. You remember that? We only started if the potassium level is 3.3. I think it was here, right here.
Yeah, that one.
Okay?
Yeah.
All right. That was an actual, similar to a question that was asked in NCLEX. So I want you to pay special attention again over here. And the principle is to remember that we are not going to treat hypokalemia. I mean, the patient with a hypokalemia with regular insulin, because regular insulin will drive the potassium back into the cell. That is the reason why insulin is also given to correct hyperkalemia. Now, a lot of times you are going to have patients who have kidney failure or renal failure, and the doctor will order dextrose plus a bolus of insulin. And the reason is if you have a lot of potassium, so hyperkalemia, what's going to happen when you give insulin and glucose, again, the glucose is going to pull potassium, 2 parts of potassium along with it. And therefore, it will reduce your potassium in the blood. So insulin is a treatment for hyperkalemia. How is it going to act? Because when you give insulin, potassium goes into the cell along with the glucose. Okay? Remember that for renal. A problem with renal patients, particularly in end-stage renal failure, is hyperkalemia. So usually the way we treat this is by giving insulin, if it's a rapid correction that we want. Or if we want to have a slow, then what we could do is we could give a K-oxalate enema, and that would be another way to treat hyperkalemia. All right? Okay, so the next treatment, do you remember DKA? D for dehydration, and then K for the potassium, and A for the acidosis. How do we treat the acidosis? Well, we treat the acidosis by giving insulin. only short-acting insulin is used for the correction of hyperglycemia. And by the way, subcutaneous absorption of insulin is reduced in diabetic ketoacidosis because of dehydration. Therefore, we use IV routes instead of the subcutaneous route. Okay? So the IV infusion usually consists of a mixture of regular insulin with normal saline. You do not need to memorize this, but usually it's going to be an IV drip. This is called an insulin drip. And we have to do blood glucose levels every hour when we do this, because hypoglycemia may develop rapidly with correction of ketoacidosis, and therefore we want to make sure that we are not going to overdo it. Okay? So we usually decrease the blood glucose levels, and a target is going to be a decrease in 100 milligrams per deciliter per hour. This is usually the target that's going to be used by the physician in calculating the dose of your insulin. We never allow the blood glucose to fall below 200 during the first 4 to 5 hours. Why is that? Because when you rapidly correct hyperglycemia, it may shift water rapidly to the intracellular space, and therefore it's going to now cause cerebral edema. Why? Because of the fact that it could cause cerebral edema. Let me illustrate why that would be, okay? So supposing that this is your veins or your blood vessels, and this is your brain. Okay. So it was before something like this. The concentration was so high in your veins, but now you're going to rapidly correct them, and maybe now it's only 2 left, 2 particles. Notice that you have 3 particles over here. Where would fluid now go? Where would fluid go?
To the brain.
To the brain. It's because the brain is going to be much more concentrated. See this? It has 3 particles. We only have 2 particles over here. The brain will rapidly absorb all the water over here. It will cause cerebral edema. And that's exactly the complication that we are trying to avoid. Cerebral edema is a very common problem, particularly in children. And that is why we don't want to rapidly correct hyperglycemia. Okay, so you're thinking, why is it that in diabetic ketoacidosis, why can't the doctor just give like 50 units or 100 units of insulin? Well, if you do that, what's going to happen is there's going to be a rapid shift of fluid going into the brain. And therefore, the patient that didn't die from diabetic ketoacidosis, but they will die from cerebral edema. All right? So it's very, very important. Now, we always make sure that we want to give 10% dextrose whenever there is going to be a decrease of, it should be below 250, not 50, 250. We want to add glucose whenever that is going to occur, right? Okay, so as far as the electrolyte correction is concerned, we usually give it as supplements. And then, of course, we never use sodium bicarbonate to correct acidosis. It is only infused if there is going to be a severe acidosis that threatens the patient's life. However, it usually is going to be avoided because rapid and early correction of acidosis with bicarbonate may worsen hypokalemia and cause, a worse condition. Okay. The correct answer here is letter C. And let me just write again the principle because you keep on forgetting. All right. Letter C is the correct response. What happened over here? In acidosis, correct Do you remember this now? You keep on forgetting. So in acidosis, we correct the potassium first before giving insulin. Look, why again? Now, let's say that you have a potassium of 2.0 over here. And now we're going to go and a lot of glucose, hyperglycemia. If we give insulin, what's going to happen is that this glucose is going to pull your potassium along with it. So glucose plus potassium. Therefore, this potassium of 2.0 might become 1.9. You're going to kill the patient. All right? So your patient's potassium level is already low at 3.3, and giving insulin would lower it further, possibly therefore killing the patient with a life-threatening arrhythmia. So the first priority is to administer potassium and then to administer insulin. Understood?
Professor, I have a question. So
Sure.
if it was, let's say, 3.5 or 3.4, would that make a difference if the potassium was a little bit higher?
Yes, because you remember, what is normal potassium? It's anywhere from 3.5 to
3.5 to
5.
5. Yes.
Mhm.
Okay. Because I wrote down only give insulin if the potassium is 3.3 or above, but if it's below 3.3, do not give insulin at all. Contact doctor.
Correct. Or if there's an order for insulin, you would never give that insulin.
Okay, I understand.
Mhm.
Okay.
Okay, so remember that that's the principle. You want to correct the potassium abnormality first before you go with the with the insulin. Okay? It's a very common question in NCLEX, and it is something that you would have to remember. So that's why I wrote here in acidosis, correct the potassium first before giving insulin. Because if you administer potassium, if you administer insulin, what's going to happen is that it would lower the potassium further and therefore would cause arrhythmias. Okay. I realize we're past the 1 hour mark, but let's just finish this one. Now, you remember that cerebral edema is a complication that may evolve at any time during treatment of DKA. And this is very common in children. So it is important that we need to monitor the patient for signs and symptoms of cerebral edema. So what are the signs and symptoms of cerebral edema? Well, the patient can have abnormal responses to pain. They can have decorticate and decerebrate posturing. They can have seizures or palsies. They can have abnormal respiratory patterns, and they could have deceleration of their heart rate from tachycardia all the way to bradycardia. And so this has got to be identified. If this is identified, we usually give mannitol or hypertonic saline as a treatment for cerebral edema. So again, understand why cerebral edema occurs when, if this is the cell and this is the blood vessel, and now your glucose all of a sudden is now going to be less than the particles in the brain, what's going to happen is the fluid that you're giving is going to go immediately to the brain, causing cerebral edema. Okay? All right, let's go ahead and take a 5-minute break. And when we come back, let's continue with the other complication of diabetes, and that's HHS. 5-minute break. Okay, I hope that you're all back. Let's go ahead and continue. So let's see this poll over here. Okay, so notice it says, in addition to insulin and volume expansion, the insulin is for the hyperglycemia, right? The most urgent goal in DKA includes prevention of. We want to prevent hypokalemia. The levels of the other electrolytes like A, C, and D are going to be considered true. But if the serum potassium is not monitored and replaced as needed, what's going to happen is the patient may develop life-threatening arrhythmias. And that is why letter B is the correct answer. Okay, so we have not discussed this, but anyway, you could do it by elimination. So one of the test strategies that you need to employ is that when you're not sure about something because you haven't encountered it, what you could do is through the process of elimination. So let's see why I eliminated letter B. Ketones are present in the urine. Well, this is a correct statement about diabetic ketoacidosis. You remember that ketonuria and ketonemia are present in DKA. The other thing is that metabolic acidosis with Kussmaul's breathing. That's also a correct statement because as a compensatory mechanism, the patient will try to blow off excess acid through the respiratory system. And letter D, potassium should be above 3.3 during treatment with insulin. We emphasize this. So it's most likely that letter A, therefore, is the correct answer. But why is it the correct answer? Well, the reason is there's another complication of diabetes mellitus known as HHS, which we will discuss next. We said that in DKA, the blood sugar usually shoots all the way to around 400, but rarely above that. So the correct answer is letter A. Okay, very good. You all got it correctly. So we just said that DKA usually does not increase above 400. But it says over here, a patient with diabetes with a blood glucose of 639. What supports DKA? So despite that fact, it's saying, what would make it a DKA? Well, letter A, there should be ketones, right? Because we know that there should be ketonemia and ketonuria. And of course, metabolic acidosis and Kussmaul's respiration. So A, B, and C are distinct findings in patients with DKA. Okay, so let's take a look at the options over here. Ketones in the urine is expected when I'm ill and is no cause for alarm. The first part of the statement is okay, but the last part of the statement is bothersome. So we need to teach this patient more about DKA. Letter B, it's normal for my blood sugar to be 250 over 3 to 350 while I'm sick. Well, this is not going to be normal. It's abnormal. And letter C, I will hold off taking my insulin while I'm sick. We all know that illness increases insulin requirements. It should increase actually his insulin dose during periods of illness. And letter D, I'll check my glucose every 3 to 4 hours and take liquids when I'm sick. This is exactly what you need to teach them. It is important for them to monitor their blood sugar levels and, of course, to prevent dehydration, meaning to say that they need to consume liquids. Okay, so now let's go to the other complication of diabetes mellitus, and that is going to be your hyperosmolar hyperglycemic state, or HHS. This is one of the two serious metabolic derangements that occur in patients with diabetes mellitus. Again, similar to DKA, it is a life-threatening emergency that, although less common than DKA, it has a much higher mortality rate. Okay, so remember that. It has a higher mortality rate than DKA. So what differentiates it from DKA? Well, there's going to be hyperglycemia, hyperosmolarity, and dehydration, but there's no significant ketoacidosis. When I say significant, meaning to say you remember the 5 MEQs of ketones. So most patients present with severe dehydration and accompanied by neurological deficits. It once was referred to as hyperosmolar hyperglycemic non-ketotic coma, and it has had so many names. However, this names was changed because coma is not going to be in all cases. It was found in less than 20% of patients with HHS. So let's take a look at the pathophysiology of HHS. So before we go there, I wanted to again emphasize to you this concept. So if we have two compartments over here, and one compartment has two particles, and the other one over here has 3 particles, it is most likely that if fluid is going to be introduced fluid is going to go into this area, or it could also draw fluid from this area. Okay, so an area of greater concentration So this is the prevailing principle that we're going to understand in order to have an idea of what happens whenever we have HHS. Okay, so let's begin with the cell over here and the blood vessel over here. So the blood vessel over here will have a lot of glucose. So this is hyperglycemia. So which one is more concentrated, the blood vessel or the cell? And the answer to that is the blood vessel. And so what happens is that because of the increase in concentration of glucose in the vascular bed, water is now going to be drawn from here and therefore will cause your dehydration. So this is what happens whenever you have HHS. You will now have hyperosmolarity, meaning to say that there's going to be an increase in the pull of fluid and therefore would cause your neurologic problems. Because what's going to happen is that you're going to dehydrate the brain as well. So that's exactly what happens whenever you are going to have your HHS. So let's go to this poll. Okay, so let's take a look at this question. Hyperglycemic hyperosmolar syndrome is characterized by hyperglycemia. Usually the blood glucose is over 600. Your hyperosmolarity, meaning to say that there's a lot of concentration in your blood vessels and dehydration, and there's no profound ketoacidosis. As a result of this, there's going to be neurological problems. So what are some of the possible neurological problems resulting from dehydration of the brain cells of a patient with HHS? Well, weakness on one side of the body, that's a neurological sign, that's hemiparesis. And then body shakes, that is seizures, which could also be a neurological sign. Increase in urine output in proportion to the increase in blood glucose. This is going to be not a neurological sign. Unable to respond verbally to questions is a neurological sign. And letter E, uncontrollable pill rolling, is not a sign of neurological dehydration, but rather is a classic sign of Parkinson's disease. So the correct answers are A, B, D, and A, B, and D. Okay. So that is the characteristics of HHS. Let's find out exactly what is the difference between DKA and HHS. All right, let's take a look at this one first. DKA actually occurs very rapidly within 24 hours. The signs and symptoms include your Kussmaul's respirations, abdominal pain, nausea, vomiting, acetone breath, and signs and symptoms of dehydration. In HHS, it develops over several days, and the symptoms are going to be polyuria, polydipsia, weight loss, and volume depletion, plus neurological symptoms. Okay, so that's easy to remember. DKA occurs quickly. HHS occurs over several days. The signs and symptoms of DKA, Kussmaul's is the more prominent one, and acetone breath. And in HHS, it's going to be your neurological symptoms. All right, let's go now to other criteria for the distinction between the two. DKA is most common in type 1 diabetes, but increasingly seen in type 2 diabetes. In HHS, it is in type 2 or in previously unrecognized diabetes. The reason why there's no production of ketones or profound ketones in patients with HHS is because they still have relative amounts of insulin that prevents for the great accumulation or formation of ketones. So that is one of the other important distinctions between the two. And the last is that in DKA, usually the plasma glucose levels are above 250 all the way around to 400 to 600. But in HHS, it's classic to be over 600 milligrams per deciliter. So that is the most significant. And in addition to that, in DKA, it's going to be 5 MEQs or more of serum ketones. In HHS, it's less than 5. All right. And in DKA, you're going to have both are going to have acidosis. So those are the various distinctions between HHS and DKA. So let's summarize that. Which occurs fastest? The onset of the complications or symptoms occurs earliest when?
DKA.
Okay, good. Fast. Early. What is the laboratory? Both of them will have hyperglycemia, but what is the laboratory finding in DKA that's not found in HHS?
It's less than 600, the glucose. 400, around 400, and HHS is more than 600. The glucose.
Yeah, okay. Ketones, okay. So ketones over here will be 5 MEQs or more, right? And
Okay.
over here, there will be less than or no
Ketones present.
ketones. Okay. Dehydration will be both of them. Okay. And name one symptom in DKA that's not found in HHS.
Kussmaul's respirations.
Okay. What else? It's present in DKA, but not in HHS. Your Kussmaul's respirations. And your acetone?
Breath.
Breath. Okay. Over here, it is going to be your neurological symptoms. All right. How about the blood sugar level in DKA? It has to be what?
250 or above.
250 or above, but usually does not exceed
350.
400 to 600, right?
Mhm.
Okay.
Over here, it exceeds 600. It's over 600 milligrams. So most likely, the highest glucose level that I've ever seen, I thought I was going to die. When I saw it, it was 900. I've never seen a blood sugar that high. But anyway, that immediately tells me that this is not DKA, it is HH.
HHS.
Okay, good. All right. Let's take a look at this question.
Mm.
Okay. So this is a tricky question because it could be DKA or HHS, right?
Yes.
But why is the answer HHS, letter A?
I guess because metformin is for diabetes type 2, or I don't know.
Very good. You remember who is taking metformin? Who takes metformin? Type 1 or type 2 patients?
Type 2.
Type 2. Which one is, you remember, HHS doesn't happen in type 1 diabetes mellitus. It happens only in type 2.
2. Mhm.
Okay. So this was tricky. So you have first to take into consideration that this is type 2 diabetes mellitus. How did we know it was type 2? Because he's taking oral hypoglycemic. Oral hypoglycemics are not taken by your, what do you call that? Metformin is going to be taken by patients who are type 2 diabetic and not type 1. All right? Type 1 patients will take insulin as their treatment. Okay, so he's going to be at risk for HHS. Oh.
Mm.
Okay, this question is a little bit difficult, so let me interpret it for you. So a patient has HHS. So it says, why is it that there's too much blood glucose in these patients? What's causing? Okay, so is it caused by fluid overload? And that is no, obviously, it doesn't have any relationship with it. How about hyperglucagonemia? So you remember that in the pancreas, there are two types of cells, the alpha and the beta cells. Okay. So if this is the alpha cells and these are the beta cells are responsible for releasing insulin. Alpha cells are responsible for releasing glucagon. So that when we are not eating, glucagon is going to be higher, insulin is going to be less. When we ate, glucagon will decrease and insulin will increase, correct? But in patients who have diabetes, there's too much glucagon, and that is why you have hyperglycemia. So this is correct, okay? Glycosuria and dehydration does not have anything to why there is an increase in your blood glucose levels. But this one is going to cause it. You remember hepatic glycogenolysis? When there's not enough glucose going into the cells because there's no insulin, the body now looks for other sources of energy. And the stored glucose, where is the stored glucose found mostly?
The liver.
The liver. And the other ones will be in your muscles, right?
Okay.
So it's formed in the form of glycogen, it's stored in the liver. So abnormal releases of glycogen obviously will cause an increase in blood glucose. And if you are deficient in insulin, there's nothing to counteract it. And therefore, this will also increase the hyperglycemia. So this tells you the three mechanisms why there's too much blood glucose in these patients. The reason why there's too much blood glucose is that there's an abnormal secretion of the alpha cells of the pancreas, causing release of an overabundance of glucagon being released by the alpha cells. The other one is excessive breakdown of glycogen from the liver. And lastly, if there is not enough insulin to counteract the effects of glucose. So this is a little bit of a challenge, but basically describes the three mechanisms and explains why we have a lot of glucose in these patients. Okay. So what are the signs and symptoms of HHS? And they include, again, signs of dehydration. As we said, it develops over several days. So usually these patients are going to have polydipsia, polyuria, as well as signs and symptoms of dehydration. And we understand that dehydration occurs as a result of your hyperglycemia. So again, I'm going to explain that. If this is the cell and this is the vascular bed, and we have a lot of glucose over here, what's going to happen is it's going to pull the water from the cells into the vascular bed. Therefore, we have cellular dehydration, which would therefore stimulate the hypothalamus as far as the thirst reflex is concerned. So you will have polydipsia, and because now a lot of water is drawn over here, you will now have polyuria. Okay. Now, why the neurological changes? Because if this was the brain, you're now going to dehydrate the brain. And that is why we're going to have a lot of neurological changes. There will be nausea, vomiting, weakness, seizures as a result of the dehydration of the brain cells, and of course, general signs of dehydration. Okay, let's go to another poll. Excellent. We don't want rapid correction of acidosis because it could cause the situation to deteriorate, including neurological decompensation. Okay, so what are the diagnostic criterion for diagnosis of HHS? So again, there has got to be a serum glucose level above 600 milligrams per deciliter. And then, of course, we have to have our acidosis. I cannot get my pen to work. Okay. And we're going to have acidosis because of the decrease also in, as shown by a decrease in serum bicarbonate levels. The urine is not going to have ketones, or if present, it's only in small amounts. There's going to be hyperosmolarity. Hyperosmolarity means to say that if you're going to measure a cubic centimeter of blood and count the number of particles, that's what's known as serum osmolarity. And if it's above 320, then that means to say that there is hyperosmolarity, and that is the criteria. And notice that there's variable anion gap over here. In DKA, there is going to be a normal anion gap. And lastly, neurological symptoms inclusive of stupor or coma. Okay, so when you're caring for a patient with HHS, you remember that the treatment will now have the potential of causing water to move back into the brain. So when you now bring water back into the brain, there's going to be a threat of cerebral edema. And therefore, letter A is the best response. You look for cerebral edema. All right, so what are the treatment and how is it different as far as treating diabetic ketoacidosis? Well, we also do vigorous IV hydration as well as giving electrolytes and insulin. So it's similar to how we treat, obviously, DKA. But in addition to that, we also identify what might be the precipitating factors. Why did they develop this complication? So sometimes stress or illness might be, or maybe non-compliance with their medications. So the fluid management is going to be the same. And let's take a look at this question. Excellent. It's letter D is the correct answer. Again, we're looking at HHS based on their symptoms. So this one, letter A 72-year-old history of diabetes with a blood glucose of 300. So we know that this is less than 600 or 400. So it's most likely to be DKA. 66-year-old diabetes mellitus plus ketones in the urine. Remember that ketones in the urine, it didn't specify how much, but it says positive, then it's most likely to be DKA. This one, 6-year-old with polyuria, polydipsia, abdominal pain, and vomiting. While this could be a possibility, but we're going to come back to that one. 69-year-old diabetes mellitus infected, so the patient has an infection, is on metformin, which means to say he's type 2, and the blood glucose is 600, which points mostly to HHS. So in letter C, the patient is young, and therefore it's most likely that this patient might be a type 1, although not always the case. But the younger they are, the likelihood of a type 1 diabetes mellitus is going to be high. That is the reason why letter D is the correct answer.
I don't know.
I just said the same thing, Patricia. I was like, wait. This is
Okay, so you can what do you call that? You can
process of elimination.
yes, process of elimination. Okay. So do diuretics decrease blood glucose? I mean, decrease insulin production? We don't know. Okay, so let's just remove that. Beta blockers. What do we know about beta blockers? You remember I talked about beta blockers last week?
Yes.
Yes, this has got to be one of them, right?
Yeah.
This beta blockers is going to be one of them. It has been found to inhibit insulin secretion. And actually, Tylenol, we don't know. Non-steroidals, we don't know. The other one that can contribute to the decreasing insulin secretion is actually diuretics. This is new evidence. So diuretics and beta blockers have the potential of decreasing insulin secretion.
But Professor, with the diuretics, because they're already experiencing severe hydration, this is post them getting the medication, the IV hydration, like to manage
Yes, correct. And or even if you're just on diuretics, you're predisposing yourself to dehydration anyway. So if you're already a diabetic and you are now going to severely dehydrate the patient, then it's most likely that it will produce HHS. Very good reasoning, Dominique. Okay, all right. Let's go to a next question, another question. Okay, so remember that dehydration is present in both DKA and HHS. But the answer here is letter D, Kussmaul's breathing. When do we see Kussmaul's breathing? In DKA, okay? Because they're trying to remove the ketones through the respiratory system, all right? So the correct answer here is letter D. All right, so in any case, both DKA and HHS are going to have complications once treatment is instituted. And that would include hypoglycemia as well as hypokalemia. And so those are important complications to remember. So let's go to a case study. Here is a 73-year-old male with a history of type 2 diabetes presented to the ER due to a change in mental status. So immediately, what are you thinking of? If he's type 2 and he's having a change in mental status?
HHS.
HSS.
Yes. Okay, very good. So at 12 o'clock, the 73-year-old male with a history of diabetes type 2 was brought to the ED by the spouse for changes in mental status from his baseline. The client's wife reports that he woke at 6 o'clock to complete his morning routine. At approximately 11, he became unaware of his surroundings and began sweating profusely and slurring words. Breath sounds are clear but noted with a fruity citrus odor and deep rapid respirations. Confusing because now we have a fruity citrus odor. When do you find this? HHS or DKA?
DKA.
DKA. Okay, very good. Sinus tachycardia per cardiac monitor. He is awake and alert, pupils equal and reactive to light. So just thinking about it, how then will you differentiate HHS and DKA if it's HHS and DKA? We're going to rely on the lab, right? Because one is pointing to HHS and the other one is pointing to DKA. So let's see what labs are going to show us. So the temperature is 99.5. So the temperature is high because of the dehydration. Pulse is 118, the same thing because of the dehydration. Respirations might be because of acidosis. And then, of course, these are the medications. He's on metformin, empagliflozin, and valsartan. So metformin means to say that he is a type 2 diabetes, mellitus. So let's go to the next one. Which 4 findings are the most significant? Okay. Breath sounds are clear. So the lung sounds is not significant, correct? How about history of type 2 diabetes?
Yeah.
Yes.
Yes. Points to the fact that he might have a complication of it. The respiratory status. Remember, respiratory rate is 32. And fruit citrus odor and deep rapid respirations. So this is going to be a finding. How about circulation? Pulse rate is 118 and the blood pressure is 97/66. This should be a concern.
Yes.
We're talking about pupils, right? No, pupils are equal and reactive to light, so that would be okay.
Okay.
A temperature is mild, it's 99.5, but the mental status is going to be important. And the medications also could be important, but the 4 were only limited to 4. So these are the 4 important ones. Okay? All right. So now that we have identified this, let's go to the second question. The lab reports are now here, and let's take a look. The ABG, the pH is 7.20. That means to say it's acidosis. So we have a acidosis condition. The bicarb is 32. So which means to say what? There's compensatory mechanism, correct? And the glucose is 435. This is what we are wanting to find out. 435. What is this? HHS or DKA?
DKA.
DKA. Positive ketones, is that going to be
DKA.
DKA, okay. And a potassium of 3.4. Okay, that's low, right? All right. The nurse starts an IV and reviews the labs. For each finding, click to specify if it is consistent with ketoacidosis or HHS. Each finding may support more than one condition. Each column must have at least one correct option. Is the pH acidosis present in ketoacidosis?
Yes.
Ketoacidosis.
But you remember in HHS, there's not necessarily acidosis, so we can leave that blank. How about blood glucose? Blood glucose is going to be 435. This is characteristic of ketoacidosis, but not HHS. Why? Over here, it should be around 600 or more, correct? All right.
Yes.
And the serum creatinine, all right, 1.9. What does serum creatinine point to you?
Renal failure, renal problems.
Or dehydration. Remember, BUN and creatinine reflects
Kidney function.
hydration status. So if this is going to be high, it's likely because of dehydration. Is there dehydration in ketoacidosis and
Yes.
HHS? And the answer to that is yes. It is present in both, right? How about the urine is positive in ketones? This would be true for ketoacidosis, but not in HHS, right? It should be negligible. So this would be the correct answer to this question. All right. Now, at 12:15, the patient voided 30 ml dark amber urine, sent for urinalysis, comprehensive metabolic panel CBC and ABG, IV of normal saline, started 2 liters oxygen per nasal cannula, capillary glucose 440. And it's the same medications, but the vital signs, unchanged temperature, the pulse is a little bit better, respiration's a little bit better, blood pressure almost, and pulse oximetry on 2 liters is much better, okay? And now we have we already have this laboratory report before. Okay. So let's go to complete the sentence. The problem the nurse should address first is correcting the pH, restoring volume, or lowering the glucose. What is it?
I would say restoring sorry.
The volume?
Okay, so do you remember the acronym DKA? We treat the what first? The D
The
is
hydration.
hydration. The K is the potassium.
And
The
the
A is the acidosis with insulin, right?
Yes.
So the priority here is going to restore the volume to correct the dehydration. So letter B is the correct answer. Very good. All of you almost got that. I mean, all of you got that correctly. Okay, let's go to the next frame. The client is diagnosed with ketoacidosis and the nurse begins to plan care. All right, hero RN, here we come. For each nursing intervention, click to specify whether the intervention is indicated, contraindicated, or non-essential. All right. So let's see how you Is the question displaying correctly on you?
Yes.
Yeah, okay. All right, let's discuss. What is glycosylated hemoglobin A1C? Do you remember what this is?
Is the glucose that is linked to the hemoglobin, and it's supposed check the glucose in long periods of time, like 4 months. So it's more like a stable.
Excellent. Very good, Patricia. You remember that very well. Let's just discuss about hemoglobin A1C for those who did not remember that. Now, a red blood cell has a lifespan of at least 120 days. So it's around 4 months, right? So what is contained in RBC is hemoglobin. So if this is hemoglobin, actually, it is going to absorb glucose. And it will now reflect the amount of glucose that the body has had for the past 120 days. Okay, so it is a reflection of average blood glucose levels in 4 months. And usually what we would like to have is a hemoglobin A1C, a normal hemoglobin A1C is usually less than 6. Now, this is going to be relevant to determine how the patient's blood glucose has been controlled over the past 4 months. But do you need to know this at this time if the patient is having ketoacidosis?
No.
No. So it's not essential, right? It's not important at this time. How about teaching the client per-sleep breathing? And I think I talked about per-sleep breathing last week. So what does per-sleep breathing do? You remember the patient was having tachypnea? Would per-sleep breathing be useful in this instance?
I guess it controls the volume of CO2 that is being expelled, because you purse your lips, so it's just I don't know how to say.
No, you're on the right track, Patricia. You remember I told you last week, anytime a patient is having respiratory difficulty, you want to control or make it effective for them. So per-sleep breathing is something like this. You're controlling the expiration so that you can slow down your breathing, and you also can increase your expiratory volume, which means to say you're going to blow off those excess acids. So this is going to be very, very important. So remember, NCLEX like this per-sleep breathing. It's a intervention to slow down the pace of breathing. So it's effective for anyone that is experiencing respiratory distress. Okay, always remember that. Okay, so we would like this as an indicated intervention. How about administer glargine insulin? Indicated, contraindicated, or non-essential? What kind of insulin do you use for HHS and DKA?
You said drip, insulin drip IV.
Yeah, but what kind of insulin? You remember there are several types of insulin. You have regular
Short
insulin.
acting.
Yes. Oh, so what is a short-acting insulin? A regular insulin. That's what we use in treatment of DKA. We do not use glargine because regular insulin can be given IV and titrated to slowly achieve the goals. Glargine is a kind of insulin, is long-acting, and therefore injected once daily and therefore could not be used for short-acting action. All right? So this would be contraindicated. We are not going to have this. So administration of insulin glargine is going to be contraindicated. Okay. How about inserting a Foley catheter? How did you all answer this? Is it ever acceptable to insert a Foley catheter routinely?
No.
No, you remember we do not want to have an increased risk of infection. Patients with diabetes already have a high risk of developing infections, and therefore an indwelling catheter would even pose a greater risk for infection. So therefore, this would be a contraindicated action. How about administer IV potassium? What was the potassium level again? It was
3.4.
3.4. So would it be indicated, contraindicated, or non-essential?
Well, it says less 3.3 or less, you should replace it.
Correct. We need to replace it because there's going to be a risk for arrhythmias. So it should be indicated. And how about monitoring for ECG? Is this something that's indicated, contraindicated, or non-essential?
I think indicated because also tell us the levels of potassium when the potassium goes down can be a
Very
arrhythmia.
good. If the patient has hypokalemia, why? What is the greatest threat? The greatest threat is arrhythmia,
Yeah.
right? Very good. So we need to monitor the ECG. Okay, let's go to the next one. So at 12:15, he voided 30 mLs of dark amber urine. And the orders now are going to be the following. So let's see what the orders are. Admit to ICU with diagnosis of DKA. Give 1,000 IV normal saline over 30 minutes. Then start normal saline with 20 of K at 125. Start regular insulin infusion at 0.1 units per kilogram per hour after a fluid bolus. Finger stick blood glucose hourly, and obtain electrolytes every 2 hours. You are going to be busy if you are going to take care of these patients. That's why they usually are transferred to ICU. And then, of course, continuous cardiac monitoring. So you review the order. What action should the nurse take while implementing the treatment plan? Select all that apply. Okay. What action should the nurse take while implementing the treatment plan? Select all that apply. Did we begin insulin? You remember, if you remember the acronym, what is the order of treating a patient with DKA?
First, dehydration.
Huh?
Dehydration first. Dehydration.
Yes. So we're not going to do letter A because you remember if you do this, it's gonna cause more hypokalemia, right?
Yes.
So remember that. Do not treat the potassium, the glucose first. You're not going to begin the insulin. All right. Anticipate holding insulin for low potassium levels. Is that true or false?
True.
True. You do not want to give insulin for anybody with low potassium levels. So you remember what I said. If you have a potassium of 3.0 over here, and you're now going to give insulin, what's going to go into the cell?
It goes the glucose with the
Glucose
potassium. Potassium too.
and potassium. Okay. So you don't want to make this happen. All right. So therefore, you are going to hold insulin for low potassium levels. Request IV fluids with dextrose when glucose levels start to normalize. Yes or
Yes.
yes. Okay. So you remember once the glucose levels normalizes to around 200, we usually are going to start giving dextrose to prevent rapid correction of the hyperglycemia. Allow client to eat when status stabilized. Well, this is going to be okay, right? Because then you can increase the blood glucose levels that way. So letter D is going to be okay in order to prevent hypoglycemia while there is insulin that's being given to the patient. And monitor this for symptoms of fluid overload. We have a bolus of 1000 cc's over 30 minutes. What's the complication over here? Fluid overload. And therefore, this would be a correct statement. Okay. So now the new thing is that we now have new vital signs. This at 12 o'clock, we already reviewed that, 12:15, 1:30. Why is this? This should be around 14:30. Okay. So anyway, temperature. Better, right? How about the pulse? Better, worse, or the same?
It's doing better.
Better, okay. Respirations?
Yeah, it went down.
Better, right? Blood pressure?
Improved.
So is it better or worse?
It is better.
Better. And pulse oximetry?
Is oxygenating better.
Okay, oxygenating better. So this has something to do with the next question. So the nurse reassesses the client after giving a fluid bolus and starting the insulin infusion. Which findings indicate the treatment plan has been effective? Select all that apply. Okay. Is the blood pressure an indication that the patient fluid is being addressed? Yes, right? You remember the blood pressure was 97. The reason why he's hypotensive is because there's not enough fluid. And now you're going to give fluids. That means to say that it will improve the blood pressure. How about the mental status? Says
Yeah.
over here.
Awake, alert, oriented. Yeah, it's doing better.
It's much better, right?
Yes.
Okay. How about the breath sounds? Breath sounds are clear but noted with, this is unchanged, right? This is unchanged. And how about the pulse?
Yeah.
Is it better or worse?
It's better because it decreases.
Yeah. You remember when you're dehydrated, you have tachycardia. So if you're giving enough fluid, your pulse rate should come down. So therefore, the pulse rate is an indication that he is improving. How about the capillary glucose? Where is our capillary glucose? Right here. 435 right over here. And 440 over here. 435 over here. It's still bad, right?
Yeah.
So there's no
much change. Almost no change.
It's almost the same, correct?
Yeah.
And pain levels, there's nothing about pain, denies pain. So the correct answers here are A, B, and D.
Okay.
Okay. So that ends our discussion on diabetes and its complications, DKA and HHS. So important points. Please remember dehydration correction first, then potassium, then you correct the acidosis. How do you correct the acidosis? By giving insulin. What kind of insulin? It should be rapid acting insulin, and that is going to be your regular insulin. How about the route of administration? Could not be given subcutaneously. Why? Because if a patient is dehydrated, the absorption of insulin is going to be slow. Okay? So I thank you once again for participating in this webinar, and I hope that that helps. And tomorrow we're going to continue with pharmacology, and I think we're going to be talking about drugs that are used for depression. Okay? Have a great day, and hope to see you tomorrow.
Thank you so much, Professor. See you tomorrow.
Yes. Thank you. Thank you.